First of all, we need to start from what is the unmet need, because this is a medical oncology meeting, and one would argue, why would you have a urology abstract? Because it's a neoadjuvant trial, and I'm guilty of being a medical oncologist, so to speak. But we work very closely with the urology team within MD Anderson, and we've developed this platform of testing agents in the neoadjuvant setting for high-risk disease. Why? High-risk disease is that disease that is locally advanced and has a very high probability of relapsing and recurring if you decide to treat it with a single modality approach, whether it will be radiation treatment or a prostatectomy. And having said that, we have an answer for this locally advanced disease and the combination with ADT in the setting of radiation therapy. But as you have probably also reviewed the data, it is a more safe approach for those gentlemen who are older in age, rather than what we unfortunately see in our days, 50-year-olds or 55-year-olds diagnosed with high-risk locally advanced disease. So we have an unmet need. And the question is, given the data that we've seen in the metastatic castration-resistant setting, and if we were to extrapolate the observations that we've had in breast cancer, for instance, we should be able to move these agents earlier and identify those patients who are likely to benefit from such new agents, given that we do know that the androgen signaling is a driver of the disease from the beginning. So this is an excellent example of how the disease in the earlier stages may have less of a plasticity to adapt to the pressure of the selective therapy. Hence, moving up front, a drug like abiraterone or enzalutamide should be beneficial as long as we identify who we should treat. So we actually had all this in mind when we designed this trial, that we wanted it to be randomized so that we can compare to the failed arm, let's call it, which is LHRH alone. We randomized patients to receive ABI plus LHRH versus LHRH alone. And then at the end, we had prostatectomy specimens for both arms, and we could compare the residual tumor, the pathology stage, the other measures of cytoreduction that were more exploratory, associate with the outcome, which is essentially what we're all looking for, a better survival with less disease recurrence, and of course, find predictors of resistance or response inversely. And I think we hit all of those endpoints because we were able to conduct a study that turned out to be feasible from a molecular perspective. We looked at the pathology stage and we saw a trend for improvement in the ABI arm. However, when we use the exploratory methodologies that take into consideration the residual tumor in the sense of the percent of cancer cells that are left within the volume of the tumor, we were able to see that there were very significant differences in favor of ABI. Now, what does that mean? It's just an exploratory measure, and if it does not correlate with outcome, it means very little. Now that we have a follow-up of this patient cohort that exceeds 4 years, we can safely say that there was a strong statistical association between this exploratory measure and outcome, disease recurrence. Then we went on to assess the molecules of interest. Namely, we wanted to see if a drug like abiraterone, and the same would apply with enzalutamide, would incur a more aggressive phenotype. And that's a hypothesis that's trending right now. Well, we didn't see it in the castration-sensitive setting. And actually, we saw that the ABI-treated tumors were performing poorly with regard to proliferation. They were not proliferating anymore. Androgen signaling was inhibited. And when we looked at those markers that were involved in the resistance, ARV7 showed up again. Even the presence of it was associated with resistance to treatment. And then we saw something for the first time reported for abiraterone in the castration-naive. The presence and the increased expression of the glucocorticoid receptor, especially paired with the ligand, the cortisol in the prostate, associated with a higher tumor epithelium volume. So taken together, we have these observations of an improvement when you're treating with ABI and LHRH in the neoadjuvant setting, but that does not pertain to all cases. Again, heterogeneity of the disease, and what lies ahead is deciphering and knowing a priori who is going to be the patient to perform well with that combined modality, meaning treatment that is systemic and then OR.